Welcome to the June 2021 edition of the Prehospital Care Research Forum Journal Club podcast. The Prehospital Care Research Forum is dedicated to the promotion, education, and dissemination of prehospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine prehospital emergency care. Here, with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Jeff Ruhlman, and I'm joined by Dave Page, Dr. Tony Fernandez, and Dr. Bill Toon. And it is my great pleasure to welcome the authors of this paper, Dr. Quatman-Yates, Jessica Wiseman, Elizabeth Sheridan, and Dr. Carmen Quatman. The name of the article we are going to be reviewing today is Assessment of Fall-Related Emergency Medical Service Calls and Transports after a Community-Level Fall Prevention Initiative. And this was recently published in the journal Prehospital Emergency Care. And moving to our next slide, I just want to remind you that this discussion is paired with an article written by our columnist and podcast panelist, Dr. Tony Fernandez and EMS World, called Journal Watch. We encourage listeners to check out this article at emsworld.com under the category of education and training. Thank you all for joining us today. As we begin, we want to remind our listeners that you can use the chat feature on your screen to type in any questions and comments, and we'll bring those into the conversation as we go. So let's dive in. Once again, I just want to thank all of our co-authors for joining us today. So starting off, if we can all just introduce ourselves, the co-authors, if you don't mind, and just tell us briefly about yourself and how you got involved in the great world of EMS research. So if you don't mind starting us off, Dr. Quatman-Yates. Great to see you. I can see you, but thank you.
Yeah, there you go. Sorry, it undocked itself. I couldn't find the unmute button. So, hi, I'm Catherine Quatman-Yates. I'm on faculty at The Ohio State University. I'm a physical therapist by clinical training and a researcher interested in health services research and specifically
We may have gotten a frozen screen there. Maybe we could have another one of our co-authors introduce themselves, because I think
I'm happy to. I'm Dr. Carmen Quatman. I am Katie's identical twin sister, actually. I'm an orthopedic trauma surgeon at Ohio State University, and I specifically became interested in pre-hospital care with my geriatric specialty, recognizing that we really don't understand the patient that shows up at our doorstep and how we really need to have a better way to understand the medical issues these patients face, because often they don't have someone to provide the full history. And I, during fellowship, actually worked with a group of local paramedics who had started their own community paramedic program. I did some ride-alongs with them, and I became very interested in trying to understand what was going on in the pre-hospital stages around falls and fall prevention.
Great, thank you. Great to have you here, Dr. Quatman. And Beth?
Yep, I'm Beth Sheridan. I am the Associate Director for Research in Orthopedics at Ohio State. I work with Dr. Quatman and Dr. Quatman-Yates. I have a master's in public health, so that's what's got me interested in this topic, besides working with Dr. Quatman. And when she came back, she brought the idea of working with the paramedics back into trauma, so we got interested that way. And Jess can go.
Hi, I'm Jess Wiseman, and I'm a clinical research coordinator at Ohio State. And as Beth said, I'm also have a master's in public health, and so prevention is something that we're very interested in. And of course, Dr. Quatman has a heart for preventing falls, and yeah, so we got connected with her and Dr. Quatman-Yates, who is also very interested in that, and that's how we got started in pre-hospital research.
Thanks for sharing that. Thank you all for joining us. I'm not sure, Dr. Quatman-Yates, if you want to try again, or if you're audio only.
Can you hear me?
Yes.
I'm not sure what happened, if my signal got blurred or whatever, but it just says paused on my screen. So maybe, did you hear when I introduced myself before, or was I talking to myself?
Heard the very beginning. Yeah.
Okay, so I'm a physical therapist by clinical training, and I'm very interested in implementation research specifically, which if you read the article, has some unique elements to it and very community-based. So I kind of served as the methodologist, but also from a physical therapy standpoint, we're always interested in preventing falls. So that's where I came from.
That sounds great. Yeah, thank you. Thank you all for introducing yourselves, and thank you once again for being here. So this article and your research, of course, is about fall prevention. But if one of you can just tell us a little bit about epidemiology of falls in EMS and why are falls a big issue for us? Why are we trying to address this in the first place?
Is my mic still on? I don't know
Yeah.
what's happening with my tech issues here, but I can see you. I don't know what's happening with mine. I can't find my mute button. But in any case, well, from a fall standpoint, you know, we have a big challenge after someone falls and gets injured in terms of being able to help them recover, especially older adults who might have a hip fracture where there's a high mortality rate afterward. So, you know, the idea is the earlier we can actually get in and prevent it, the better. And in terms of those who are most vulnerable, we have a lot of fall prevention opportunities out there and programs out there for people who can actually get to them outside of their home, but that requires them to get there and to also recognize their fall risk. So part of the interest in the pre-hospital side, especially the paramedic and EMS world, is that we can see people, or we can actually get a glimpse of the home by virtue of using them as extenders, right? So you have a unique slant, a very good understanding, and also a natural rapport, because patients are calling for a reason, right? And they know that they need help, and paramedics are great at helping people in vulnerable situations. And so fall risk is something many patients are afraid to even talk about and to acknowledge that they may be at high risk, especially if they're frail and if they're afraid of being expected to leave their homes. And so it was a natural interest to kind of figure out how we could really get to those people who are most vulnerable, who aren't already reaching the programs that are out there, and who really do need the help. And one of the early pilot projects before we even made it to this intervention stage was showing how often after somebody calls, they may call again, sometimes even on the same day, for just, sometimes it's a lift assist, and sometimes, you know, it's an actual fall with an injury. But the idea is that falls are actually a signal of other health decline as well. So it really became a really nice lens into really helping people who might not otherwise be getting the help that they need. And so we knew that there were some system gaps we could help fill, and that's kind of where we went with it.
Thank you. Yeah, I definitely agree. I mean, I know in my own personal experience as a paramedic, there are some patients who we see many, many times for falls, and we often kind of address this in the emergency setting, but there's very much an area that we can try to prevent this, and we want to think about how we can prevent this from turning into an emergency. And that's what I think is so exciting about community paramedicine, how we are kind of extending our paramedics to try to be more proactive. So in this study, I believe you worked with one city-based fire department and their community paramedicine team. Would you mind telling us a little bit about the setting of this study, the EMS system design, and then how their community paramedicine program came into place? Did it come into place for this study, or was it already in existence?
Sure. Well, actually, it was. I'm going to let Beth tell the story. She was our first connection, and she's actually a resident in the community. So, Beth, do you want to take over from there?
Sure. Well, I'm gonna turn on my camera per our request. Oh, you popped back up. So serendipitously, I was reading the local like magazine that gets mailed to us, and I had seen that the fire department that's in my little community had just been starting a community paramedicine program. And Dr. Quatman had talked about the community paramedicine work that we were interested in looking about. So there was a Memorial or Labor Day festival in the community. So I went and stalked the firefighters at the event and introduced myself and was like, hey, we work at Ohio State. We're interested in doing these things. And they actually, that was the first day that they existed as community paramedics. They hadn't actually started their program yet. So we got in on the ground floor. That was their first event. So we were able to get there right when they were starting to kind of see what they were doing and kind of grow with them. Starting with the grab bar project is kind of our start project with them. That's my part of it.
Great, thank you. And if we could just move to the third slide, and that talks a little bit about the exploration phase. So moving into table 1. So if you don't mind, Dr. Quatman-Yates telling us a little bit about the implementation science aspects of this, and then EPIS, starting off with exploration, since this is something that we don't see in our typical EMS study. So very interested to see how this worked out here. Or any other co-authors. Oh, there you are.
There we are. Yeah, when I go off screen, my mute button disappears, so I don't know what's happening. I can't see the tabs to do anything. But in any case, the exploration phase, yeah. So my work again is in implementation, and so we tried to use the structure for growing what we had interest in. We didn't have a recipe, so to speak, since it wasn't really something that was out there in terms of fall prevention. And though our community paramedic partners had been trained in the community paramedic model, part of their training had not been specifically around fall. So in that exploration phase, it was really just them growing the community paramedic program that they had sort of been trained and exposed to, while we were starting to do sort of a needs assessment around fall prevention. What tools did they need? What tools did they already have? What were the opportunities? What were the barriers to being able to really engage successfully in what we call evidence-based fall prevention? So lots of studies are out there in terms of what you can do in terms of identifying somebody who's at risk and what their maybe specific fall risks are, but not a ton out there for what community paramedics could implement, right? So we were just interested in sort of growing that model, and that was the exploration phase, while they were refining their own processes about how they were going to go out in the community and engage with their citizens. We were just doing lots of exploring conversations, brainstorming, evidence searches, that kind of thing.
So the city didn't even have a community paramedicine team. To figure out how to get it started. So let's move to the next phase, preparation.
Oh yes, I'm sorry. I was explaining I went into the next phase. My apologies. But yes, they were doing their work on their own. They got the training in community paramedic. They found the funding to do it. They decided how they were going to staff it. That was the exploration phase for them.
Would you mind telling us a little bit about how they decided to staff it and what their training was like? I understand they did some training, but kind of how intense was it? Who was training them?
So I feel a little bad telling their story for them, but so this is from my perspective of what they've shared with us. They had kind of noticed some need in their community. It was an aging community in general, and they had been hearing about the community paramedic model, and it's a 2-station fire EMS unit anyway. So they had been trying to envision how this would work for their community. It's a relatively small by square miles community, but has a relatively high population given the the place that they're at, with a growing aging community and a lot of people that wanted to age at home. So they had actually gone and gotten training, I think through Dr. Dan Swayze's community paramedic training model, and then from there used what they learned to kind of build what they thought would be best for the community. And that started out as, I believe, once every third shift, they had a team that was up and running, and they were just kind of doing what they could. If they had heard that somebody had called frequently, or if there was somebody that they knew in the community specifically, it wasn't really systematic at first. It was really just kind of word of mouth from their own units about who could maybe benefit from some additional help in their community. So that was kind of where they were at. And it was a city-funded initiative. So they had gone and asked for some additional budgetary resources to support people in sort of an overtime model to run the extra community paramedic truck. So that was how they were running it at first. That emerged and evolved over time as they got kind of more effective and more efficient with it, but that was where they sort of started.
Great. And how did you become involved? It seems like it was something that was, they were kind of already thinking about community paramedicine, but not necessarily falls, but this whole partnership, how did that start off?
So Beth kind of shared the story. It was very incidental, but a very nice, way to get in terms of they falls weren't really on their radar. They recognized it as a problem, but they weren't sure how they were going to address it. And with our great interest in that area, we just really started those conversations about how they could do it. What were the opportunities that they had even in the moment on the EMS scene versus what they might have. So the scene of a 911 call versus what they could do when they weren't there in an emergency context. And so the conversations just evolved. It was really like, let's talk about a patient and what you're experiencing. What would you feel comfortable doing? One of the things they recognized very early on that was, at least from a physical therapist's perspective, a little bit like, wow, I can't believe we weren't doing that, is it's very easy to go in someone's home and talk to them about the scenarios that they're facing, but they don't often necessarily say, hey, let me watch you walk to the bathroom, or let me just see you move in general. And part of understanding the fall risk is not just asking the questions, right? It's actually observing the people moving and looking around their house for specific concerns. And so what we were really looking for was like some simple screening tools that went beyond just the asking questions, and added to what they were already doing, which was trying to scan the house for fire hazards. They were checking smoke alarms. They were just checking for other health needs, like did they have food in the refrigerator? Did they have social contacts that could come help them? Those kinds of things. So they had a whole set of questions that they were asking, and it was sort of homegrown from their own acknowledgement of what was probably important. But it wasn't necessarily evidence-based in the sense that a lot of times we do evidence-based practice for fall prevention, and it wasn't necessarily evidence-based in terms of the way we communicate information. And so we actually brought in, so Jennifer Garvin, who's listed on the authorship team too, is a health information management specialist. So she was able to come in, and we were talking about sharing of information, because there's a disconnect between where they were collecting information in their 911 call system, and then of course what they're documenting at the scene of a 911 call, and then from their community paramedic work. And those systems didn't necessarily talk to each other. So we had to come up with a way to share the information sort of safely, so that they would know from the 911 scene what would be important, why they should go back in as a community paramedic team and address it. And then from the community paramedic side, how could they communicate information when they go in and get a more in-depth analysis of the scene and really understand more of what this person's facing? They have a whole new vast set of information that would be very helpful if the person calls again and on the 911 scene, that they could then maybe have access to, like, what are the greatest concerns? Where is this person most likely located? Who could you call instead of just transporting to the hospital if there was perhaps not an injury, but it was more just a health check, but that you wouldn't want to leave them at home because they're going to call again soon. So just trying to really connect both the communication gaps and the skill gaps that they had around fall prevention.
Really interesting. Thanks for sharing that. And as a EMS researcher, and yeah, all of us are EMS researchers, we know how important data is. And I thought it was interesting that the community paramedic teams, they started off with paper records. And we know how difficult paper records can be to read after the fact and abstract. And then later on, it's unlikely that another team, 911 paramedics or in the hospital or another team might have access to that paper record. So it was really interesting to read about how you were able to integrate data systems, because I imagine this would have been way more difficult to do this implementation science project and write up the research if you didn't have all this data in one place. So that's great. So moving on to the next slide, the preparation phase. I know you talked about most of this already, but what sort of training was involved in training the community paramedics in this fall prevention, in addition to the standard community paramedicine workshop?
Yeah, so the preparation phase was before we really implemented anything. It really was that discussion point about like what are you struggling with, and if we asked you to have the patient move, what would you feel like you would be concerned about? If we asked you to scan the home environment, do you have a systematic way of doing it and documenting it? We were just really trying to understand their world, and they were trying to understand our world. So preparation was really just that kind of, I guess I would call it like partnership engagement, getting to know each other and what we could offer for each other, and then also sharing with them the evidence from our lens, and then them sharing with us, you know, from their world, what either the procedures already were or what evidence they were aware of. We actually pulled up articles and talked about them. So there's, you know, other published articles in community paramedic work, and we were able to kind of showcase that to them and talk about what they were doing, what they could do, what would be interesting, what would not work for them. So that was the whole preparation phase, really getting in the stages. And also, I'll say from the research standpoint, this is also where we were putting together our plans for what we could do and how we could get IRB approval. You know, because there's a dance you have to do around that, right? Between implementation, which could be more on a quality kind of outcomes improvement type of work, versus what we would consider something we were working toward generalizable knowledge. So we were often just talking about what would be our goal in terms of generalizability, what would be our goal just in terms of community improvement, you know? So it was a fine line to dance, but you know, ultimately we came up with some solutions that we think worked well. Also, this is when we were seeking funding to be able to trial new things. So we were in that phase of applying for grants and just getting support, financial support in whatever way we could to be able to try what happened in the next phase.
Yeah, these great programs, unfortunately, don't pay for themselves, but you're able to make it work. You had talked about a couple of research terms like generalizability. Of course, this is something that was only utilized in this one community, but we want it to be generalizable and applicable to other communities potentially to adopt this program. So definitely we thank you for writing up your results and sharing this so others can look at this. We're now going to dive into methods with our methodologist, Dr. Tony Fernandez. He has a couple of questions about how you actually went about conducting this research side of this.
Good afternoon, and thanks so much for joining today. I apologize, I was having some technical difficulties, as it seems like is going around today. But I love the conversation that I jumped back into, where you talked about some back and forth with the EMS crews and what you learned and what they learned, and how you actually ended up working together. And that kind of leads me into the first question, which is, as we talked about, a lot of our audience is budding EMS researchers, and understanding the model for improvement and how you implement the scientific framework, I think would be really beneficial to the folks who are listening and watching today. So can you give us a little background just about the processes?
Sure. So from a scientific standpoint, if you are a person trying to do implementation, you often can lean on these implementation frameworks, which would normally say, like, we kind of like our conventional science, like a recipe. I'm going to do X, Y, and Z. I'm going to measure what happens after X, Y, and Z, and that could be very helpful. But especially in a world where there's not a lot of evidence to support what you're going to do, and what we're trying to do is sort of build it along the way and refine it along the way, there is an alternative, and that is to kind of think about what I call the quality improvement slant and model improvement. Model for improvement gives you opportunities to kind of try something in a small test of change type of way, and then learn from what you did, and then try to improve it the next time. And so we used a lot of those tools. And if you're not familiar with the model for improvement, you can just Google it. And there's lots of little training videos online. But part of our work with the team was to actually train them up in the model for improvement so that they could start to do it for themselves. And so that was the nature of what we were hoping for. It wasn't about like us as researchers coming in and telling them what to do. Everything was a really thoughtful approach. That's the community-based participatory action research approach that was kind of described a little bit there, not in full depth, but it's about viewing ourselves as equal partners in this process. We have things to bring to the table, they have things to bring to the table, and at the end of the day, we hope that we've empowered them with new tools to improve what they do, because we don't have the funding and the time, or that's not our area of expertise, is to stay involved on the research lens and the methodology lens for on and on and on. Our goal is that we can empower them to do that on their own, which they've gotten very good at. Even as their teams have changed, their processes have been such that it's sort of a part of their culture now to do certain aspects of the quality improvement process around the community paramedic work. And so they're just kind of naturally doing it. It's not even a method, so to speak, anymore, as much as it is just their operations.
Yeah, that's great. I mean, just to get it to be part of what they do day to day through your work is, I don't want to get to your results too quick, because I do want to spend some time on your methods, but to have a project that's impactful like yours with the give and take, I think is really, it's really the way forward for our field. And to that note, to that end, can you talk to us a little bit about how you continue to gather information and plan and refine the community FIT program?
Yeah, so a lot of it was really, we'd come in, we'd meet, and we'd say, what are you struggling with this week? Or what was, based on what you tried last week, what didn't go well, what did go well? And then, so it was just each week revisiting, and that led to a set of systematic processes that they would try to implement at every place, including a set of forms that were paper at first about, this is the exact information that you'll collect, right down to the details, making sure that they didn't miss certain questions. And then as they moved on to the electronic world, that meant they actually built, through one of our small grants, we had a partnership with Health Call, which allowed them to sort of build their own system directly aligned with what we had done on paper, that made it a little bit more seamless for them to document and then share that information eventually. So that even the documentation process had that optimization mentality to it. It was like, it took me a really long time to get through those forms. Do we really need to ask all these questions? And it just kind of evolved from there, to the point that at one point we actually decided it was better for them to separate the fall part into almost 2 calls. So they screened initially, just kind of like thinking, is this person a good candidate for a more intensive, kind of comprehensive home evaluation around falls? Or is it okay just to say, you know what, they're okay for now, and we can focus on these other things? And also they noticed, as often is the case for frail and vulnerable people, is that it can be uncomfortable to talk about some of these things, and to really build that rapport, it took maybe more than one visit to start to talk about the difficult things, like, do we need to bring you in more help? Is there an alternative living situation we should be considering? And even getting to know some of their other care providers, such as their PCPs or their family members, to kind of just envision on a personalized level what this person really needs.
And you really are kind of embodying what I think we envision as a field when we talk about community paramedicine. It really does sound like you involve the field providers and the patient and all of their providers throughout the community. I think this is some really great work. And you spoke to a little bit just now about how a patient was entered into the program, and there were a couple of different pathways, I believe. It says that one, you can be identified by a 911 visit as a candidate for a home visit, or there were some options for self-referral or referral by physicians. Can you talk a little bit about, you really did diversify how you can get patients, and I think that's a testament to your success. Can you kind of give us a little more information about that?
Yeah, so if you read a little further along the document, this is something that also evolved as kind of that triaging system, and we kind of label people in different categories, those that are going to self-refer versus those are, more than likely not to self-refer. And so initially they were getting some self-referrals, especially as the community paramedic program itself started to get a little bit more, I don't know, say like branded, I guess, marketed in the community, where people became aware of it in their newsletters and just in different town hall meetings, and it made the the news several times, that kind of thing. So people would call and ask. When it really started to take off in terms of self-referral because primarily we were focused on the 911 referral system at first. It started to take off through, we had, Beth sort of mentioned this earlier about a grant that allowed us to look at grab bar installation from the paramedics themselves. What we realized was like, boy, one of the hardest things is that people cannot access or maybe get overwhelmed by the process of trying to get grab bars installed. Where do I install it? What kind of grab bar should I buy? Who's going to do it for me? All these questions sort of would come up just from the patient perspective and from the, community paramedic medics themselves. Like, boy, it would be so great that we've helped them off the floor like 4 times in their bathroom in the past month. If they just had a grab bar rather than this towel rack that they keep grabbing that's not safe, perhaps, we could make a big difference. Well, they started to kind of look into their own ability to do this. Many of them were installing fire alarms on a regular basis, had a great comfort level with just, home improvement type of work. And so working with their legal office and just doing some more exploration on their part, we eventually got to the point where they were able to train themselves into how to install really nice grab bars.
Oh.
We were able to find some philanthropic donors who were willing to help us buy the grab bars and other home equipment that could just bring up the safety of a person's home so that we were able to test it. They got very good at sort of deciding who and who would best benefit from it, where in their homes they would benefit from it, even to the point of talking with the patient if they had an occupational therapist or a physical therapist about where on the wall it could be best placed given the person's height and specific needs. And we learned over time that it was so successful, more people were actually calling, hey, I heard you have this great grab bar, program, that the city actually took on budgeting it for the future years. So even when the grant money and the donor money sort of ran out, they were finding that it was so beneficial, especially with some of the data that you see here in this paper, that it was of value for the city to sort of take that on to protect their citizens. So that was a big win, I think.
And that must be really rewarding for you and your team when something like that comes out of your work.
Yeah.
So I know we're going to talk about this a little bit later when we get to the results, but I think it'd be good to tee it up here to kind of help the audience understand a little bit. And when we talk about the clinical pathways, one of the things that you talk about in the results section is the Stopping Elderly Accidents, Deaths, and Injuries Toolkit. And if you could, I think that's going to be new to a lot of folks listening. So what kind of information, what can you teach us about that toolkit?
Yeah, sure. So really that was devised out of the idea of having primary care physicians be able to implement that in their clinics and the community centers. And so a lot of different stakeholders are using that tool that is just a quick kind of screening tool to help understand who's at risk, how much at risk, and what you can do about it. And they even have some decision trees around what you can do. So we started that just because that is so already strongly used. It's well marketed, it's evidence-based, and we started with that really as one of our early ways of building our clinical pathway, recognizing that it wasn't necessarily designed from a community paramedic standpoint. So there were things in there that wouldn't necessarily make sense, but we did try most of it. And then we just adapted from there. So they do implement the questionnaire that goes along with it consistently with their screening process. And then some of the other components in terms of referrals and things like that were, I'd say, like adapted. So we started with what worked and what didn't, and then over time it evolved into their own operational processes. And what's sort of unique is that it really does help close some of these healthcare gaps, right? Like a lot of times if somebody goes to their primary care physician and it's identified that they're a fall risk, they'll say, well, make sure you get, your home evaluated for potential grab bars, and they'll make these suggestions, but it doesn't necessarily remove the barriers for the patient to do it. Well, the goal with the community paramedics is like, well, let's talk about what you need and let's address it. So
that's great. This is a really, really interesting paper to read. One of the things I think we've mentioned a little bit, but you talk about in the paper, learning health infrastructure. And can you explain that to us a little bit?
Yeah, so from a methodology standpoint, there's this idea, and I think people are using it almost a buzzword term now, like quality improvement. Mm-hmm. And this goes hand in hand with the learning health system. The idea that you collect data that you can use and communicate that data to both help improve your patient quality outcomes, but also to improve your operations for the future and perhaps even contribute to the research knowledge base. So our goal was really helping them get good data and then being able to use their data consistently to continue to improve their own processes. And then maybe eventually, and we've got to that point hopefully now, where we can help disseminate that for a greater, kind of the greater good. And so they're getting ongoing graphs about how they're performing relative to the different initiatives that they had, specifically around falls. And so sometimes they give us their data, we build graphs, but really they've gotten good at it themselves. So it's really more me, all of us kind of just check in with them just to see if they need any help, but they've all gotten very good at it. So using that, the data that they're getting to, know who is going to be at risk, who's their frequent callers, frequent fall callers especially, so that they can get ahead of the game and go from a person that might be calling regularly for a lift assist to offsetting that and only just having some check-ins. And if you saw the triaging system at the bottom of the list, it was really about like moving people up from like kind of a needing a lot of help with a lot of visits to fewer visits and just monitoring, because we've gotten them safer in their own home and healthier in their own home. And that also led to some conversations around, which we're still working on, optimizing communication with other healthcare providers, because we know that's a big gap, right? Like, how do we get the information? Great vision on the part of the paramedics in the home, but then they go see their PCP who's never been in their home and never seen it and doesn't necessarily know. And perhaps patients aren't being fully forthcoming when they go to their primary care physician. So wouldn't it be great if we connect those dots?
I love this entire integration. And Tony, I have to give a shout out to the Ohio State University, which is, appropriately well represented on this podcast. So we gotta definitely, shout out over there. But the integration of all these services and all these experts and the diverse backgrounds of the authors on this paper make it so strong, because you had so many different aspects to it, right? And I just wonder, we often put the ambulance at the bottom of the cliff. We wait for everybody to fall, and then we're going to take care of them. And I wonder if there was any thought in your design about integrating some of the basic ambulance services that often take people home after they've been in their, whether it's a doctor's visit or perhaps putting the ambulance at the top of the cliff. So it's that whole reversal of the philosophy around prevention versus response, and those frequent 911 provider or 911 users seem to be the people who we're often taking home. And if some of those EMTs just take a look around and just flag that, then the community paramedic can come in and do a much longer intervention after. So is there a nice checklist that you were thinking, okay, if we can get this to people who are just bringing people home, the local caretakers, it seems like the team could be the patient and the community paramedic, but also a wider team of just caregivers.
Well, there's two components there, and then I'm probably going to have Beth, Jess, and Carmen jump in on the second part, because it's actually one of the next phases of the project. But the first part is that one of the things we recognize is, obviously, if you've worked with one, EMS group, you've worked with one EMS group, right? Like, everybody does it differently. So in our case, it wasn't necessarily that they were necessarily transporting them home from, say, a hospitalization, or like a lot of the private ambulance services are used for that around here. And obviously there's different state practice laws. So in terms of generalizability, this is still all over the map. We don't really understand, and payments, the way people are paid for their care coordination, all this sort of stuff is just a black box. But also, if we think about it, these are barriers, but if we're trying to do the right thing, I think we just need to keep tackling it, right?
Right.
But to your point about making sure that we are leveraging the ability of our first responders to a greater degree to really look around and do something about it, besides this transport only, like, we have no choice, we're just going to take them because maybe somebody can then help them. Like, even in the 911 scene, in theory, we could have a better capture system, a better understanding of who needs what and how we're going to handle that afterward, So I'm going to pass this off to Carmen, and maybe Beth and Jess can also join and chime in about the next phase, which was more on sort of understanding those factors. And I don't know if Carmen can turn her screen, but that's what she's been really diving into with her part of the work.
It is both refreshing and scary to see that an expert like yourself, who really isn't inside of EMS, now understands the EMS nightmare, the entire patchwork of our system, and how it just can be so different from one place to the other. So fun. It's not something we're very proud of. In fact, it gives us a lot of headaches. But I love this cycle. While we wait for them to unmute here, I love this cycle of plan, do, study, and this framework, this EPIC framework, which seems like could be followed by other researchers, right, Tony? You could see that sort of having a stepwise approach to sort of a constant revision and improvement. So, yeah.
Hi, I was hoping that Carmen would unmute to take this question. This is not.
Hiding panelists. I know. Let's see who talks. Good job. Thanks for taking one for the team.
I'll chime in if I can, Beth, but I know you've been deep in the data. So.
Your question is, as far as like when people get discharged from the hospital, what's the next?
So the cycle, right? The cycle we think of 911 is they call, we transport, and then it's just over. But in fact, ambulances and what we call the EMS system involves those private ambulance services sometimes as well. And they're often taking those patients back home. So you have the EMT who is literally putting people back in their home after this fall, who could look around and go, hey, we're part of the system too. And it's sort of that circle that you're discussing in the paper. And I love the way you've set this up, and whether or not multiple EMS agencies can talk to each other. One, perhaps it's just designed to transport people and can, do other things like look in the fridge and make sure there's food there, but, not leave the rug all crumpled up or and think, oh, okay, well, that's the fire department. They'll come pick you up again when you fall again, because that's truly, I'm an EMS provider. I go out on calls. I sometimes have to take people home, and I look around and I go, we'll be back here in no time, because there's just no network to catch all these things that I'm seeing. But I don't really have a process. I don't have a checklist. I just have years of taking bodies from one side to the other and thinking, oh, okay, well, this is just, it looks like a train wreck in here.
Ideally, I think, as you know, falls are very important to us, right? But they're not the top priority for every EMS group currently. So I think part of the issue we run into is that we're kind of fighting an uphill battle. We have found the groups that we can work with currently, like locally, and we have that network of people who have the same belief that falls are very important currently. And then we have some who are larger that have like a bigger scope of like, the opioid epidemic is huge right now, right? And so a lot of their focus on that. And so falls are kind of falling to the wayside. Well, we all know it's a big problem, but their efforts are really going to something else. So if we could come up with a checklist that would be easily deployed to everyone, where it would be like, yes, we can do that. But, more paperwork isn't necessarily the right answer to everyone.
Right.
Sometimes there's clicking a box, and I know, sometimes I hear from the guys that we work with, well, we just click whatever to get the paperwork done to move on to the next thing.
And I love, it's so refreshing to talk to you, to both of you. It's that process by which we need the paperwork to do the research. We don't have these established databases that we can just pull this kind of information from. And we also have to recruit the attention of providers who are frankly, running around with PPE because of COVID and, not really thinking about all these other pieces that seem so important, but the recruitment of those services that are willing to work with you and do the research, I just want to congratulate you, and a message to all of the folks online that are listening to this going, yeah, okay, are we in the right mood to do this? And maybe that's not the best thing. Maybe we should be looking at, what are the priorities? Because this is a big issue for older adults that keep falling and getting injured, and lack of mobility, lack of freedom really causes a huge downstream effect on their health. So, if we can catch the ambulance at the top of the hill and stop the fall from ever occurring, we could maybe have a different idea of how this works.
You got to find that champion on the squad who's going to make everyone else change what they're doing.
Right.
Which,
I
you
love
know,
it, love it.
that came up in our conversations a lot with them. So of course they were implementing. We would suggest, and then they had to implement. And so some of that was just changing culture in their own, in their own units among their own colleagues about everything. And how much do you share about the work that they're doing versus like it's just everybody keeps going and we give them little things to do. Like once we got the learning health system up and running, they created kind of a click at the 911 scene that basically sent a referral to the community paramedic program, which was nice because, and that's where you see the optimization phase come in, right? Because before that, it was like they would show up to work the community paramedic truck, and they would have to like search back and see who called. Oh, it was this person called before. Like there was a lot of like searching, or maybe they had an email, or it was just inconsistent about how they would get the information about a given patient. But then and then we talked about like, okay, on the 911 scene, do we want them collecting more information? Do we want them like implementing a frailty score or something? And we kind of came to the conclusion of like, that's more than anybody needs to know. You know enough to maybe go into the scene and be like, this person could use more help. And hey, we have this great program. Click, I'm going to send them we'll let the program figure it out, but it wasn't like
Dr. Quatman had come up with the idea of the a doctor on scene does a sick, not sick assessment. Like, does this person need treatment right now? And the idea of a frail, not frail assessment of an older person, like, do they need transport or can they stay home? And so it was that frail, not frail. Do we send them to the community paramedics for them to follow up on them later? Because we truly believe that as a paramedic, you have the idea that you can assess someone of, are they having a failure to thrive? Do they need more intervention? And you can make that assessment and decide they should be seen by the community paramedics and have more of an intervention and click that button.
You give me great hope after years of doing lift assists where I just shake my head and go, this cycle is a disaster. We're just putting people back into bed, back into a chair. They're gonna really have bigger problems in the next 72 hours. But the mode is just not working there, and then we get into trouble with patients who are left on the scene that should have been transported, and maybe they didn't even need to be transported. They just needed somebody to come in and help them. So sorry to take us away from methods, and Jeff is popping back in going, we got to stay on task. We got to get to results. Okay, all right.
Well, we have to get to results, but in order to understand the results, we need to talk about the primary outcome measures. So let's do that quick. And then we'll jump into the results. So the primary outcome measures were relative risk reduction, the number of EMS lift assists, fall calls, and the number and proportion of fall-related transports. And I think before we move forward, if you could just give us how you define fall-related transports, I think it'll help folks understand the results, and then we can see how well you did.
Yeah, so this is something I think from a generalizable standpoint, there will be some struggles because, of course, the way that people collect their information and classify calls varies, and there's even a lot of gray, even in a place that does it consistently well. So for this particular group, they actually went, the way we operationalized it was from the 911 call system itself and whatever the person, whoever called, described it as. So, I've fallen or somebody's fallen, and they're not hurt, or they're hurt, potentially hurt, and sometimes some of those calls could be kind of messy, right? Maybe they had a heart attack and ended up on the floor and said they called it a fall, but they didn't know. So it's not the cleanest measure, but it was the best that we could do, and our goal was over time it probably got a little better as they got cleaner in their own definitions of what those things are. But the transports was a little bit cleaner because they were documenting of those calls, which of them ultimately ended up going to be transported. There's also some limitations with that. Of course, somebody could have been recommended to go to the hospital and not transported. But we were trying to get as close as we could to measuring change, and I think we did a pretty good job, probably about as good as we were going to get with this group. It's gotten better, and as we move forward, we've continued our work to just kind of keep refining. It's definitely gotten better, and I'll just say that it held through COVID, which I think is their changes. You don't see it in this paper, but they were able to, even as they had to shift their priorities, their processes have been strong enough to really even shift in the face of COVID and still maintain the lower levels of call rates. So.
Well, thank you. I think this is great work. I appreciate you answering questions, and again, I appreciate you being here today. And yeah, let's talk about what you found.
Thank you, Tony. Yeah, let's dive right into our results. A lot of really good conversation here. So let's move to the next slide, the clinical pathway. So this all came out of that Plan, Do, Study Act. So if you could just briefly tell us about that PDSA and then how this came about before we show the numbers.
Yeah.
Thank
So the goal was, again, consistency. So with quality improvement, it really is about consistency of delivery of care, making sure that you have processes that don't leave things unscreened, unchecked, that you make decisions that are based on evidence. And so over time, this evolved into what were they going to do as their way of monitoring. This is focused on falls, but it really does represent what they're doing in general from the community paramedic program. There are other things that we don't include on this pathway here that they're doing in every visit. But this is the stuff that they're doing at the visits relative to falls, and to help inform the decisions that they were making. Like, okay, so now we've identified that this person's potentially a high fall risk and we think we can do something about it. And they seem like they'd be willing to let us come in and do something about it. And so then they would go into the home again, do a more comprehensive home evaluation using a very, the HSSAT we have shared with their, I think in the citations there, it even has pictures of things to look for. So once they got good at it, they knew what to look for, but there was actually a tool to help guide them in terms of home environment scan about things to be concerned about. And so as their team got better, they didn't have to use the same degree of instructions, but they were always documenting then consistently the different things that we were asking them to document. Or at least providing a reason why they didn't document. Maybe they ran out of time or something else came up, but it was about consistently collecting information that was evidence-based and then being able to use that information to decide what they were going to do moving forward for that patient and also for their own operations.
This pathway is great. I mean, I could see it's really good, but I'm sure it started off a little bit different. And with this kind of learning health system and the PDSA cycle, you're really able to work to build this, and seems like it's worked quite well. Let's look at the results now and see how we did. So let's move to the next slide. So here's our descriptive stats. If you don't mind just kind of pointing out some of the key numbers here and anything that you may have found most interesting.
Yeah, so I'll just say from the slant that we were taking, which is a little bit unusual, we were really interested in tracking not just the magnitude of things over time, but the variation over time, which is a common thing with quality improvement methods, especially quality improvement research. You can do, you could have an outcome measure that kind of bounces all over and then have the same average, or you could have, an outcome measure that sort of stays really near the average. And so we wanted to track kind of how that was happening over time, especially with falls. You can expect maybe a seasonal change. So in terms of where you see like per month, lift assist per month, we were really tracking the average per month as opposed to like annual basis, although the graph kind of takes it to a different level because we did it by phase. But we were monitoring at a very high resolution, like how consistently are they keeping up with this? Is it bouncing all over the place? Which is slightly different than our conventional stats around the mean and the standard deviation. And so we were kind of down and dirty. So you don't get to see it in this paper because we were focused on quality improvement. And when you talk about getting things published from a research standpoint, they want to see more conventional metrics. So our initial submission looked a little bit more like quality improvement and the final product looked a little bit more like what researchers want to see. But if you could see the graph, if we were able to show you the graphs that aren't in this paper over time, you'd actually see that not only did it like kind of drop, but it was more consistent. So they were not, it wasn't just that the number of falls or lift assists, in our case, lift assist didn't really drop. We could talk about that if you'd like, but the fall calls and the fall call transports did definitely drop and they were staying tighter. So the month-to-month variation was much better than it was to start, which was bouncing around all over the place, which tells you that you've done a good job with your system and creating operational procedures that can be consistently implemented and that you're addressing things as they come up because you've made your results more consistent. And when you have a more predictable system, you can budget better, right? You can staff better, you can do all these things. And so we really were able to get their system and their outcome measure to show that they were being more consistent in the delivery of care and better in their delivery of care.
Yeah, these results are super promising. And I think it's interesting, though, how lift assists, there's not really much of a change over time, whereas the fall calls and fall transports, we see a huge reduction, which is great. I mean, you're clearly doing something right. Can you just tell us a little bit about why you think that may have been? I know you talked about it in the paper. There wasn't much of a change with those more common lift assists, but you did see a change with the other measures.
So a couple of different things we think we're kind of emerging here. I mean, one is just that, you know, in some ways, lift assist might be just a new color. Like we may never be able to, like it's our red flag, right? It's like we need to do something for this person because they fell, but maybe they just sort of slipped and didn't get injured. And so some of it might just be that the lift assists just are the people that haven't gotten intervention yet. We are now working on looking at, so for those people that had interventions, like who are they recurrently calling, which may mean that the lift assist for the people who are in the system did actually go down. It's just our population health level, which is kind of what we were going after, did not. So that's a whole other problem to sort of tackle. The other thing is, because we were intervening in some homes and that maybe somebody has a grab bar and they were able to grab the grab bar and slow down their momentum so they fall, but it's more of a lift assist than a fall with injury, and it would have been an injurious fall, right? So we were able to, and I should have said that before, the way that we were measuring just the fall calls was somebody who kind of had a potential injury as opposed to just the lift assist help back to a position of mobility and leave. So that we were able to even offset like an injurious fall. So they still fell, but they didn't get injured when they fell. And there's, of course, the measurement issue that we were kind of talked about before in terms of what somebody calls a lift assist versus what somebody calls a fall, and if there's some gray areas in terms of how that was being classified. So that could also be part of why we didn't see much change. It's just that we weren't, we hadn't fully addressed the measurement issue around that metric.
Yeah, and that definitely makes a lot of sense that it's that early intervention, that if you can hit that less severe fall with that lift assist, you definitely still want people calling at that early phase and try to prevent it from turning into more severe, consistent falls. Thank you. So we only have 2 to 3 minutes left. Our time just flew by. It was so interesting hearing about this project. So I want to give our panelists, anyone else, a chance if they have any last minute questions, anything they want to add or discuss briefly before we finish up.
I know we won't have a terribly long amount of time to just discuss all of these papers, but I do want people to read the full paper because I think it's very worthwhile. It's in PC, and just love seeing some of these graphs that show us kind of adjusted odd outcomes by phase here, and just how visually you can see that sustainment, that implementation phase really bringing down that fall, the risk of falls and the average monthly fall calls. So so sometimes I get lost in the numbers, but this very visually nicely represents that drop. And congratulations again. I think all of us are looking for this kind of just, you know, decrease, find a way to get these down, and great job.
Thank you. I just want to say that this would not have happened. The group of paramedics we worked with were very special. So, you know, they were very interested in the data and very motivated, and I wish they could have been here today to share their side, but, you know, they just really were a great team to work with. So it's a great partnership.
Thank you again. Thank you so much for joining us today. And as a reminder, we have the Education Research Journal Club podcast on Friday, June 25th. We'll be back here with our next clinical podcast on the second Monday of the month. So that'll be July 12th. Thank you all for listening. Thank you so much to our co-author, to our panelists and the paper co-authors for sharing your excellent research. And we definitely look forward to another great discussion with you next time. Have a great rest of your day.
Thank you.